Rapid Fire Biostat Review Part 3. Let's begin. A study is done to assess the relationship between smoking and congestive heart failure, and it is determined that the risk of congestive heart failure development is 5% in non-smokers and 15% in smokers. So 5% in non-smokers would be the risk in the unexposed, whereas the 15% in smokers would be the risk in exposed. And now what do we have to calculate? We have to calculate the attributable risk of smoking, and that would be AR, that is risk in the exposed minus risk in the unexposed, which is 15 minus 5, which is 10%. So over here the correct answer is B. And just a quick review, that attributable risk is the difference between the risk in the exposed minus risk in the unexposed, and over here it came down to be 10%. Question 72. 3 similarly priced inexpensive tests are available to evaluate for breast cancer. The sensitivity and specificity of each test are given below, and which of the following testing strategies is the most appropriate? So we know that we have to begin with the screening test, and after a screening test we have to go with a confirmatory test. And we also remember that for a screening test it has an N and sensitivity also has an N, whereas confirmatory test has a C and specificity also has a C. So you have to begin with a test which has high sensitivity and then move to a test which has high specificity, right? So let's see which is the test which has highest sensitivity is test 3, and the test which has the highest specificity is test 2. Therefore, you're going to do test 3 followed by the test 2 if test 3 is positive. So the correct answer is A. And if they asked us that we just have to do one test, then we will choose a test which has a good specificity and sensitivity, not the highest but average, or you can say like the two are balanced, both good sensitivity and specificity. And then if they asked us to just do one test, then we could probably do just test number 1. So the appropriate order of tests is to move from a more sensitive test to a more specific test. Sensitive tests have, we already know, low false negative rates and and they are good for screening, whereas specific tests have low false positive rate, and therefore, like we know, that the tests that are good for screening have high sensitivity, and the tests that are good for confirmation and have high specificity. Therefore, we should go from a test with high sensitivity to a test with high specificity. And if they just ask for one test to be done, then we could use test 1 as a reasonable alternative, since the sensitivity and specificity both are good, instead of one being too high and one not being too high. Okay. Next on, we have a question number 73. A study is done to assess blood pressure control among patients treated with thiazide diuretics, and it is discovered that the device being used was not functioning properly. So what is the type of bias due to the device being used not functioning properly? The type of bias is known as de-measurement bias, because the device was a measuring equipment. So a bias due to faulty equipment leading to incorrect readings is measurement bias. A bias in which the participants are not treated equally is procedural bias. A bias in which external variables affect an external variable that is related to both factors and leads to incorrect conclusions about study results is called a confounder. A researcher's own strong beliefs about the existence or non-existence of an association that will lead to incorrect interpretation of results is known as observer bias. Whereas if a screening test is better at identifying diseases with longer latency periods, this is known as length time bias. So if we have a breast cancer diagnosis and we have to look for the test, then we will move from a test which has high sensitivity and then move to one which is high specificity. And if we just have to do one test, then we will choose the test that has reasonably high both sensitivity and specificity. So basically we move from a test of high sensitivity to a test of high specificity. And faulty equipment that is not able to faulty equipment that will lead to incorrect results is known as measurement bias. Whereas if in the study the people are not treated equally, then this is known as a procedural bias. Question 74. There are currently 4,000 people suffering from MS in a city with population of 1 million. 300 new cases are diagnosed each year and 40 deaths can be attributed to MS. In total, approximately 10,000 people die in that city every year. Which of the following represents the prevalence of MS? So for prevalence, you have to know the formula, that it is basically equal to the total number of people who have the disease divided by the total population of that particular city. So the total number of people who have the disease is 4,000 and the total population of that city is approximately 1 million. So our answer would be 4,000 divided by 1 million, which is B. Whereas if they asked us for incidence, then incidence is the number of new cases divided by the people at risk. Now, how do we calculate people at risk? People at risk can basically be calculated by taking the total population and then we subtract the people who are already diseased from it. So in this way, the only people who are healthy and are prone to develop that particular disease remain at the bottom, right? Because the already diseased people are not at risk anymore. Therefore, we would calculate it as the number of new people, which is 300 new cases, 300 over here, divided by total population of 1 million minus 4,000. So that would be 996,000. So you should know that the number of people affected by a condition divided by total population is prevalence, whereas the new cases divided by the population at risk, that is, we subtract the people who already have the disease, this is known as incidence. And disease specific mortality is the number of deaths that can be attributed to that particular disease divided by the total population. So if we had to calculate disease specific mortality, we will put the deaths due to that particular disease at the top, which are over here 10,000. 10,000 is the total number of people who die. 40 deaths are attributed to MS. So we will put 40 at the top and we will put the total population at the bottom, which is 1 million. So that would be disease specific mortality would be 40 divided by 1 million. Okay. So a quick review, prevalence is equal to total number of people who are diseased divided by the total population, whereas incidence is equal to the new cases divided by the total people at risk. How do we calculate total number of people at risk? It is equal to population minus the already diseased people. And then in order to calculate disease specific mortality, we find out the number of deaths due to that particular disease and we divide it by the total population of that particular area. Which of following represents the incidence of MS? We have already calculated it. It was 300 divided by, it was right here, 300 divided by 996,000. So that would be the answer D. So it is basically the number of new cases divided by the total population minus the people who already have the disease. And in order to calculate disease specific mortality of MS, we have also already done that the number of people who were dying from that particular disease 40 divided by the total population of 1 million. So the correct answer in this situation was C. Question 77. Researchers are doing a study to assess the relationship between age and type 2 diabetes. They divide the population into 3 different groups. So remember, we have 3 groups: under 40, between 40 and 60, and over 60. The percentage of people in each group who have elevated fasting blood sugar levels will be compared. So we have 3 categorical groups, and in the 3 categorical groups, we are evaluating the answer of yes or no elevated blood sugars, right? So the answer would be whether this person has diabetes or it doesn't have a diabetes. So this is basically a sort of categorical data that we have, which is a yes or no data, in which like we either have a yes or a no. Therefore the type of tests we use for it are Fisher's exact test along with chi-square. But over here, since we have greater than 2 groups over here, we have 3 different groups, therefore we'll be using the chi-square test. If it was just 2 groups, suppose people under 40 and people over 40, then we would have used Fisher's extract, but we are using chi-square because it has greater than 2 people and we are comparing categorical outcomes. So same thing over here, then we have to compare the differences between 2 or more percentages of proportions of categorical outcomes greater than 2. This is known as chi-square. Whereas if we just had to measure the differences between 2 percentages again or proportions, which is categorical outcomes, in just 2 groups, then that would be Fisher's extract. And to compare the mean values of just 2 groups would be t-test, and to compare the mean values of greater than 2 groups would be ANOVA, and pooling of data from multiple studies to precisely estimate the true effect is known as meta-analysis. So we know that if we have to compare the percentages of people with increased blood sugar, which is a categorical outcome, yes or no, in 3 different groups, we will use chi-square test. Whereas if it was just 2 groups, we would have used Fisher extract. And we also know that to compare the differences between mean values for just 2 tests, we would have used t-test and ANOVA, whereas a t-test, whereas for greater than 2 values, greater than 2 sets of people, we would have used ANOVA. Okay. Question 78. A group of researchers is trying to determine the prevalence of a disease in a population. Which of the following study types best matches the goal? So in order to calculate prevalence, we know that the best study is D, cross-sectional study. The study that determines the prevalence of a disease and does not establish causality is cross-section study. A study to calculate the odds ratio of exposure to a risk factor between the people affected versus those who are unaffected. People are already have the disease or don't have the disease, and then we have to calculate the odds of exposure. This is case control. Whereas if the people don't have the disease yet and we have to calculate the risk of developing a condition depending upon the exposure of a risk factor, then this is known as cohort study. And when there is an active intervention done to compare the tested treatment or the placebo with the current standard of care is known as a clinical trial, and the study done to pool the data from various sources to improve the power and generalizability is known as meta-analysis. So a quick review: a study that does not that determines prevalence but does not establish causality is known as a cross-sectional study. Question 79. A clinical study is done to assess the efficacy of a new diagnostic drug for lung adenocarcinoma. The results are then compared to the result of a biopsy, which is the gold standard diagnostic test. True positives is 150 and false positives are 20. So they have already given us the true positives, false positives and false negatives. So we can just make the table and put these values in the 2x2 table. So we will put the disease at top with plus minus at the top, test at the left with plus minus at the going down, and then we have the true negatives at the bottom, and then true positives at the top, and then false positives also at the top and false negatives at the bottom. Now we are going to plug in the numbers. True positives 150 goes here, false positives 20 go at the top, and then we have false negatives 50 and true negatives 130. So here goes 50 and 130. Now a 65-year-old patient with a 5-year history of dry cough undergoes the test and it comes back positive, right? So we don't know whether the patient has disease or not. The most important thing is we began with a positive result, and now we want to know whether the patient has lung adenocarcinoma or not. So you have to know that when we begin with the test and then we follow whether this patient has the disease or not, and the test is positive, then this is known as positive predictive value. And you should also know that we always calculate the positive predictive value going towards the right. So in this case, if you want to calculate the positive predictive value going to the right, that would be 150 divided by 150 plus 20, that is 150 by 170. So A is the correct answer over here, which is the positive predictive value. Now, if they change the question and they ask that which of the following represents the likelihood that the person who tests negative does not have lung adenocarcinoma, we are beginning with a test which is negative, and then we have to tell whether he doesn't have the disease or he has the disease. This is known as the negative predictive value, and you know that we calculate the negative predictive value going towards the left. So that would be 130 upon 130 plus 50, which is 80. So let's see which answer is 130 by 80, and D is our correct answer over here. And then we have which of the following represents the probability of an unaffected person. So we are beginning with an unaffected person, which means that the person does not have a disease, and then we are going to find out whether this person can have a negative test. What's the probability he'll have a negative test? So the person not having a disease is basically a healthy person, and we are basically trying to calculate specificity. So remember, for specificity we always try to go up. So we will go up like this. For specificity, it will be 130 divided by 130 by plus 20, so which will be 130 upon 150. So the correct answer for specificity over here is 130 upon 150, which is choice number C. So here you can see that they are not directly asking for specificity, sensitivity, PPV and NPV. You have to know what they represent, and from that you should be able to calculate them. Okay. Similarly, the probability of an affected person. So an affected person means that he is actually diseased. And what is the probability that he will test positive? This is known as the sensitivity of a disease. And how do we calculate sensitivity? You calculate sensitivity by going down. So how do you do it? Let's go back to our 2x2 table and go down and calculate sensitivity. We will go down, and in going down we can see that 150 divided by 50. So our sensitivity would be 150 divided by 200. So let's see if there's an option of 150 divided by 200, which will be our correct answer, B for sensitivity. So in this way you should know that whenever we begin with the disease, positive or negative, that's sensitivity and specificity. Whenever we begin with the test, positive or negative, that's positive predictive value and negative predictive value. And suppose if they ask us to do the prevalence, to calculate the prevalence, then we will have the number of people who actually do have the disease, which are the true positives along with the false negatives. So false negatives have the disease, but the test is saying that they are negative, so they are false negatives. And then we will divide it by sum of all true positive, true negative, false negative, and that would be the prevalence of disease in that particular population. Of course, it's not for the entire population, but the population that was tested. That is how you can actually like calculate the disease by the divided by the total number of people who were tested and the numerator will have the total number of people who were actually diseased. And you can also like sort of calculate it from this particular incident. So you can put the values of true positive and false negative and then put all the four values together. Let's do this together. If we can put the values of true positives and false negatives, the persons who actually had the disease, so that would be 200 divided by the total number of people who were in this particular study, that would be 150 plus 50, 200, along with this was 20 and 130, right? So 200 plus 150 would make a 350. So we can calculate the prevalence for this particular disease in this study population be 200 divided by 350 by putting together the true positives and the false negatives at the top and then taking the sum of true positives, true negatives, false positives and false negatives together, and so it comes out to be 200 divided by 350. And let's see, yeah, so if the test is positive and then we want to know if the patient has lung cancer, this is PPV, and PPV is always going down, so it will be true positive divided by true positive plus false negative. That would be false negative, right? Because this no PPV is basically like going to the right. I'm sorry about that. PPV is always going to the right, so that would be true positive divided by true positive plus false positive. And then if the test is negative and the likelihood that the person does not have the disease is negative predictive value is going to the left, it will be true negative divided by true negative plus false negative. Then the probability of an unaffected person. The person is unaffected. It means that he is basically healthy. So in healthy person, we calculate specificity. Specificity is going up. So it will be true negative divided by true negative plus false positive. Here it is true negative divided by true negative plus false positive. And the probability of an affected person touching positive, it means he has the disease. When he has the disease, this is sensitivity, send, and send is going down. So we will calculate it as true positive divided by true positive plus false negative. So here it is true positive divided by false negative. And then the prevalence would be the total number of diseased people at the top divided by total people in the study. So true positive plus false negative, which are actually the diseased people, divided by true positive, true negative, false negative sum. And this is how you calculate prevalence for that particular study. Question number 80. Which of the following, question number 81 actually, which, we are done with 80, 81, and yeah, we are on 83. A screening mammography is performed in which there are total number of 2,000 women, so that's a total population older than 50 years. 50 of them have been found to have breast cancer. So these are the one which are the new cases, and these are the total number of women, which are 2,000. Which of the following describes the annual incidence and prevalence of breast cancer in this particular population? So these are the people who already had it, right? So they were just tested and then they came to know that they had breast cancer, right? So for this particular year, the prevalence can be calculated as by the number of cases that were found divided by the total population, which is 50 divided by 2,000, and that would come up to 140, which is 2.5%. So the prevalence is 2.5%, but we cannot determine the incidence, because incidence is the ratio of the number of newly diagnosed cases in a particular year, right? So we are not newly diagnosing these people actually like had the disease, and it's just like it was detected over here and they actually had the breast cancer, right? So when we come to know about the next year and they tell us that these are the number of new cases, then we can calculate the incidence. Okay. So the screening mammo on 2,000 females, in which 50 are positive for breast cancer, the incidence cannot be determined, whereas prevalence is the number of positives divided by the total number of people who were tested. So there 84, there's a medical student who is interested in in the perception of pain experienced by patients who are suffering. So she surveyed 100 patients affected by osteoarthritis. There were 10 questions. They were to report their pain in a grade of 1 to 10, and sum of 10 pain scores was then reported as 98 of the 100 patients. Some of the 10 pain scores were then reported. 98 of the 100 patients ended the study with final scores were between 20 and 50. Two of the patients had the score of 100. What is the measure of central tendency that is affected by the two patients? So the general trend is that was between 20 and 500, but they are saying that one outlier is actually getting, one or two outliers are getting a score of 100. So because of this, the data will be positively skewed in the direction of positive, like in the direction of like the greater value. Therefore, the measure of central tendency most affected would be the mean, and mean would be the highest. So the correct answer is B. So extremely high or low values affect which value the most? Mean the most. Which value is affected in the medium or less? That's median. And which value is affected the least? That is the mode, which is the most frequently represented value. And the extreme high or low value basically affects the greatest and skews data the most by affecting mean the most, then medium in the middle, and mode the least. Mean is the average of all values, median is in the middle, and mode is the most frequent of all values. Okay, which of the following measures of central tendency is least affected? We already know that C, mode is least affected, right? Question 86. A new biomarker for severe COPD has been developed. The lower value of the marker is higher than the probability the patient is affected by COPD. Okay, the lower the value, it means that the patient is affected by COPD. So it means that towards the lower side, we have the disease patients. Upon further investigation, it is discovered that it follows a normal distribution. Approximately 2.5% of the target population is affected by COPD. Which of the following represents the correct cutoff value for severe COPD in this circumstance? So the correct cutoff value for COPD in this particular situation, for calculating it, we'll have to like draw a curve, and they are saying that there's 2.5% of the target population that is affected by severe COPD, and then we have to like determine how many standard deviation of mean would that be, below mean would that be, right? So remember, for 1 standard deviation, 2 standard deviation, 3 standard deviation, the formula that we did 68, 95 and 99. Now out of these values, which value is the one which can be equally distributed as 2.5 on each side? That is 95, right? And 95 represents how many standard deviations? 2 standard deviation, right? So since 95 has 2.5 on one side, 2.5 on another side, and the disease people of COPD are actually present below this threshold, less than 2 standard deviations. So our correct answer would be 2 standard deviation below the mean, and the answer is D. This depends on your knowledge of knowing that 1 standard deviation is 68, 2 standard deviation is 95, and 3 standard deviation is 99.7. 68 means that on each side you will have 32, both sides you will have 32, and once you divide it, it will be 16 and 16. Whereas for 95, on both sides together, it would be 5 divided into 2.5, and of course for 99.7 it would be 0.3, and then you can divide it on both sides, okay? So 68% is 1 standard deviation, which will make that remaining would be 16%, and if you divide it on each side, that would be 8%. Whereas 2 standard deviation would basically mean 95% with 2.5% on each side, whereas 99.7% would actually mean 3 standard deviation. So here is a quick review. COPD test, decreased value means increased probability that the patients are affected by COPD, and the patients that are affected by severe COPD are 2.5% of the population. How do we find the cutoff value for the test? We find the cutoff value by saying that on each side we have 2.5%, so it means that in the center we would have 95%, which is 2 standard deviation. Whereas instead, if they gave us that 16% of the population is affected, and that is like on the lower side, then we would say that on each side 16% means 68% in the middle, which is 1 standard deviation. And if they said just a total of like 0.3% were affected, then we would say 3 standard deviation, which is 99.7%. Okay, question 87. An epidemiology graduate student is following recent trends in disease prevalence, and he is noticing that in recent years there has been a significant increase in prevalence of cystic fibrosis. Which of the following best explains the phenomena? So why is the prevalence of cystic fibrosis increasing in the recent years? The correct answer is improved survival due to better management options. You know that cystic fibrosis is a chronic disease, and in recent years there are more treatment options. So the reason for the increase in prevalence is that basically management is increasing increasing, but the incidence is remaining stable, right? So we are not doing anything to prevent the disease or modify any factor that is actually like preventing the disease from happening, but better management options are making sure that the more people are living, therefore the prevalence is actually increasing, right? And then cystic fibrosis diagnosed shortly after birth, solely time bias is not an important factor. So increased prevalence of cystic fibrosis is due to improved survival due to better management options, and the incidence is actually unchanged for it. Then, question 88. Researchers are designing a study where individuals diagnosed with MS are more likely to have a history of cigarette smoking exposure. What is the type of study that would best fit this objective? So, they have already been diagnosed with MS, right? And once they are already been diagnosed, it means they are cases, right? And now we are going to compare them to controls and go back in history and ask them about their cigarette smoking exposure. So we are beginning with the disease and going back to the risk factors. So this type of study, if you remember the mnemonic, that is CCDO, this is case control study, in which we are actually going to calculate the odds ratio. So the correct answer is C, because we are calculating the odds of exposure to a risk factor in people who are affected with MS and those who are unaffected. This is case control. Whereas if we had people who didn't have the disease at this point, and we want to calculate the risk if disease development in exposed versus unexposed, that would be a cohort. If we were to calculate prevalence, that would be a cross-sectional, and if we were to do active intervention, that would be a clinical trial. So quick review. If diagnosed people who have been diagnosed with MS are more likely to have history of smoke exposure, the study would be a case control study. We will calculate the odds of the risk factor exposure in those who are diseased with MS versus those who are non-diseased. So we are beginning with the disease and going towards the risk factor. Whereas if we were to calculate the risk of disease development, people were exposed and unexposed with cigarette smoking at this time, and then we followed them over a long period of time to find whether they developed MS or not, then that would be a cohort study. Question 89. Researchers doing a meta-analysis to assess the relationship between alcohol use and liver cirrhosis, and the results vary significantly from those that are widely accepted. Why is this particular situation happening? What's the explanation that normally alcohol use is associated with liver disease, but why does this meta-analysis show that alcohol use is not associated with liver disease? And the correct answer is the researcher used lower quality studies for meta-analysis. So the quality of a meta-analysis is basically dependent upon the type of studies you're using. If the studies are already biased or have systematic problems, then the findings in the meta-analysis will also be affected. So always remember, the quality of meta-analysis depends upon the quality of studies that you choose. So the features of meta-analysis vary significantly from the established findings. This is because the researcher used studies for meta-analysis which were of lower quality. Question number 90. A group of researchers is evaluating the usefulness of plain chest x-rays in diagnosing lung cancer. They evaluate any shadows based on preset criteria. So what's the preset criteria? Shadows larger than 2 centimeter diameter are referred for further screening. Which of the following describes what the effect on finding would be if we cut or increase the cutoff value from 2 to 3 centimeter? Now this is a very important question. Normally we are referring the patients only who are greater than 2 centimeter. But suppose we begin to refer the patients who are now only greater than 3 centimeter. So what about the patients who are present between 2 and 3 centimeters, right? If they have lung adenocarcinoma, of course they are being missed, right? So because they are being missed in the initial screening test, it means that the sensitivity of the test is going down, right? And what is increasing? The test is becoming more and more specific, right? So the sensitivity is going down, and once the sensitivity is going down, what does that mean? That means that the false negatives would actually increase in that particular situation, since we said that false negatives are inversely proportional to sensitivity. So this shows that the number of false negatives would actually increase in this particular situation, right? But if they were to tell about false positives, we would say false positives would decrease. Why? Because specificity increasing, and increase in the specificity means that false positives should actually decrease, right? And this can also be like done by drawing a particular graph in which like you put the diseased people on the right side, right, which are the true positives and the false positives, and the healthy people on the left side, because we said that anything that's greater than 2 centimeter or 3 centimeter are being like referred for screening. Therefore the disease would be on the right and the healthy people would be on the left. Then this curve, like this peak of the curve, would be true negative, and this peak would be true positives, and along with true positives come the false positives and the false negatives. So this is the normal cutoff criteria of 2 centimeter. If the 2 centimeter is pushed to the right, which value goes down? This value, false positive on the right, goes down, and this value, false negatives on the left, goes up. So this tells us that false negatives would actually increase, whereas false positives would actually decrease. So this can be calculated from the data as well, and from drawing the graph as well. And you could even do it without the graph, just by using like common sense that, okay, we are missing the people between 2 and 3 centimeter, so the sensitivity is going down, which means that the false negatives are going up, right? Okay. And we also know that false negative rate is proportional to 1 upon sensitivity, and false positive rate is inversely proportional to the specificity, right? So chest x-ray, lung cancer shows shadows greater than 2 centimeter, referred for further testing. If we increase the cutoff value to greater than 3 centimeter, it means that we are excluding the values present between 2 and 3 centimeters, so sensitivity is going down, and then the false negatives are going up, but the specificity is going up. Because the specificity is going up, so the false positives are going down, right? And so the lesions that we saw that between 2 and 3 centimeters are basically being missed. So which of the following best describes this effect change, what effect such change would have on sensitivity and specificity? We have already studied this, that between 2 and 3 centimeter people are being missed, so sensitivity is going down, whereas the specificity would go up. Let's see which answer matches. Specificity would actually increase. This is the correct answer, and there is no option of sensitivity going down, right? Okay, and this is exactly what is told over here, that the sensitivity would actually go down, the people between 2 and 3 centimeter are being missed, and specificity is going up because the more larger lesions are more, there are more chances that they would actually be having the disease. Okay, a group of researchers is looking into the incidence of ulcerative colitis by age. Which of the following best describes the distribution curve that they would say? So we know that ulcerative colitis is a bimodal age distribution disease that has two peaks, one in the very young and one in the elderly. Therefore it will be bimodal distribution, and whenever the mean is larger than the median, this data is known as, or distribution is known as, positively skewed, whereas whenever the mean is smaller than the median, then this sort of distribution is known as negatively skewed. Whereas if distribution has three peaks, this is known as trimodal, whereas if there is a single peak of mean, median and mode, and they are all present at the same point, this is known as a normal distribution. So incidence of ulcerative colitis by age is bimodal. Why? Because it is in the young adults and then the elderly. Three peaks means trimodal. The mean being greater than the median and the mode means it is positively skewed, where the mean being lesser than the median and the mode means it is negatively skewed. And normal distribution is when we have one peak and the mean, median and mode lie at the same place. Question 93. A new coronavirus COVID-19 has affected a total of 10,000 population in a population, 10,000 people in a population of 100,000, right? So these are the new cases that we have, and this is the population, right? And it was found on the average 150 new cases were diagnosed every day. Okay, this is not the new cases, this is the number of cases that exist, right? So this is the total number of existing cases, and these are the number of new cases. The number of people who died was 100. So now we have the number of people, specific number of people dying from that disease, and now we have to calculate case fatality rate. Now if you know the formula for case fatality rate, that it is equal to the deaths by that particular disease divided by the total number of disease, so that is 100 divided by the total number of people who do have the disease, that is 10,000, so that comes off to 1%. So correct answer is B. So case fatality rate can basically be calculated by dividing the people dying from that particular disease divided by the people affected by the particular disease, and from this you can calculate the case fatality rate. Whereas if you were to calculate disease specific mortality, then it would be death by the total disease, death by that particular disease divided by the total population. So that's this difference. Case fatality rate has on the denominator people that are affected by that particular disease population, whereas disease specific mortality is for that particular disease has the total population as the denominator. Okay, Question 94. A 58-year-old male who undergoes colorectal cancer screening with fecal occult blood testing. He is relieved to find out that the results are negative. However, he worries that he may be false negative, as multiple people in the family has suffered from that particular disease. He is concerned that the relatively low prevalence of the disease in the population affects the results. What is true regarding the case? So, the prevalence of that particular disease in the population is low, and the patient also has a negative test result, right? And what is he concerned about? He is concerned that whether the negative result that he got was actually false negative, right? So what is in this particular situation is that he wants to know that, like, whether he is actually a true negative or not, and the test is actually like telling him that is excluding the disease from him or not, right? And it's a screening test, right? So for screening test, remember, what's the most important criteria for a screening test? The most important criteria for a screening test is sensitivity, right? And here we know that the sensitivity of test is not affected by the prevalence of the disease. Therefore, the correct answer would be C. You don't have to worry that the test has low prevalence or whatever. It's basically the sensitivity that we are concerned about in a screening test, and sensitivity is independent of the prevalence of the disease in that particular population, right? Which of the following would change if the disease in question affects significantly larger percentage of population? So previously we said that it was low prevalence disease, but now if we say that it's a high prevalence disease, what would change? We know that NPV and PPV would change, but how would they change? Increased prevalence would mean a decrease in NPV, whereas increased prevalence would mean an increase in PPV. So the correct answer is D, that the PPV would increase because prevalence is also increasing and they are directly proportional to each other, whereas NPV would actually decrease and the sensitivity and specificity in this particular situation would not change, right? So he's concerned about the negative test, which is a screening test. So for screening test, the most important factor is sensitivity, and it is inherent property of the diagnostic test, and it is independent of the prevalence. Whereas specificity, of course, like, it's also an inherent property, it's also independent of the prevalence, whereas PPV and NPV are dependent upon the prevalence. PPV is directly proportional, NPV is inversely proportional. And if for the disease with low prevalence, then what will happen to the NPV? The NPV would actually like increase because, again, NPV is inversely proportional to the prevalence. If the prevalence is low, the NPV would actually go up, right? In general, which of the following increases the sensitivity of a test, right? In order to increase the sensitivity of a test, what should you do? You should widen the definition of a positive result, right? So then more people are actually going to be screened in and more people are actually going to test positive. If you suppose say that we are widening the range of the people who are actually like in the diabetes range, we are going to lower the blood sugar value on this side and then make the blood sugar value higher on that side. So then it's going to make the test more sensitive whenever we widen the definition of a positive result. Whereas, of course, prevalence, incidence, and the number of tests are performed do not affect the sensitivity. Sensitivity is just affected by the range of the numbers, right? Okay. What increases the sensitivity of a test? Widening the definition of a positive result, right? And which of the things are unaffected by which of the things like sensitivity is not dependent upon, it's not related to prevalence, incidence, number of tests performed, it's not related to any of these. Whereas how do we increase the specificity? We increase specificity by narrowing the definition of a positive result. Then only the people who actually really do have the disease are going to be detected. Okay. So in question 97, in a survey of 200 people, 200 households with an average of 3 residents per household, 150 people actually had hypertension. So the number of people who are affected by hypertension is the total disease, which is 150, and the total population for this area would be 200 multiplied by 3, which will keep at the bottom 600, right? How do we calculate prevalence? By keeping the total diseased, that is 150 at the top, and keeping the total population, that is 600 at the bottom. So it comes out to be 0.25, that is 25%, and the correct answer over here for prevalence is B. A group of researchers is studying the association between radiation exposure and AML. They have identified a group of patients with AML, similar group of patients without AML, right? So there are some people who have disease, some people who don't have the disease. We have case controls, and from the case controls, we are going to a history of radiation exposure in the past. This type of study is best described as a case control study, because we are going from the disease to the development of risk factor, and we remember the mnemonic CCDO. Okay, so and we know from the previous question that if we do a survey of like 200 households, and then there are 3 people in each home, and the people affected are 150, we put the diseased people at the top, and then we put the total population at the bottom. 200 multiplied by 3 people in each household, so total is 150 upon 600, and that is 25%. And if we have to find the type of study in which people have the disease and then don't have the disease, and then we trace them for the exposure, so beginning with the disease going to the risk factor or the exposure, is known as case control study by CCDO mnemonic. Okay. So question number 99. Researchers have developed a new diagnostic test for COVID-19 infection, and the sensitivity of the test is 65%, specificity is 95%. So in this situation, they have already given us the sensitivity and the specificity. Where's the specificity? So specificity of the test, they are saying that is equal to 95%. Okay, specificity is 95%, sensitivity is 65. Test was performed on 100 patients affected by COVID and 100 patients that are unaffected. So the total number of patients is 100 and 100. Right, and they have given us the sensitivity of 65, and they have given us the specificity of 95. Okay. Other than that, which of the following is the number of false negative results? Right, so we have to make the table. Disease at the top, positive, negative. Test at the left, positive, negative. Then we put the positive, positive, true, positive at the top left, and negative, negative, true, negatives at the bottom right. And then we negatives are always at the bottom, false negative at the bottom, false positive at the top. We make the table. Right, 100 we know that, and 65% is the sensitivity. Now what they want us to calculate is the false negatives, right? So this is a trick question. You have to know how to find false negatives from the sensitivity as well as the total number of people who are actually diseased. You should know the formula for sensitivity, that sensitivity is going down, so it means is equal to true positive divided by true positive plus false negative, right? So the total number of people that actually have the diseases at the bottom, 100, right? And then you can put in the sensitivity 0.65. So from this, like multiplying 100 into 0.65, you can find out that the true positives are actually 65. So if the true positives are 65, the false negatives would be 100 minus 65, that is equal to 35. So 35, that is B, is your correct answer. But you have to know this formula for calculating it, that to calculate true positive, multiply sensitivity by the total number of people who are diseased. Then subtract, take the total number of people who are diseased minus the true positives, will come out the false negative people. Okay. And similarly, if they ask you for the number of false positives, similar thing, right? But instead of sensitivity, you will now use specificity, because specificity is going up. So first calculate true negatives. How do you calculate true negatives? By multiplying 95%, which is 0.95, into the total number of patients who are actually healthy, right? So that's 100. 0.95 into 100 is 95, right? So that if that comes out to be 95, it means that the false positive would just be 5 by the subtraction. So the correct answer is 5, which is A, right? Which of the following is the positive predictive value? So now you have the entire table with you, 5, 95, 65, 35. You know that PPV is going to the right. So how do you calculate PPV? 65 divided by 65 plus 5. So 65 by 70 is the correct PPV, which is the answer over here. Yeah, so they have calculated 65 upon 70 as D, which is 93%. And then if they ask you to calculate the NPV, so NPV is basically going towards the left. So that would be 95 divided by 95 plus 35, right? 95 divided by 95 plus 35, which comes out to be 73%. So let's see if the NPV over here is C, 73%. Which of the following would increase the positive predictive value of the test? You know that increasing the prevalence basically increases the positive predictive value of the test. But here we find that there is no option that is directly related to prevalence. So what is the option that was indirectly related to prevalence that will increase the PPV? Better treatment of the disease. Okay, if there is better treatment of the disease, of course the number of people disease will decrease, right? So decrease prevalence. Improving isolation will also decrease prevalence. If the patients refuse to self-isolate, yes, this is the one that will increase prevalence and thus increase PPV. So C is our correct answer. Vaccine development, of course, vaccine would actually decrease the prevalence, decrease number of people affected, and increase number of ICU beds will also decrease the prevalence. Okay. So we already know that if we are given sensitivity and we are given the total number of people of disease, we can calculate true positives by multiplying sensitivity to total disease, and from true positives and total disease we can calculate false negatives. Similarly, if we are given specificity and total number of people are healthy, then we can calculate true negatives by simply multiplying the specificity with the total number of people who are healthy, right? And then of course, like, you can just do the subtraction, and if there is a disease that is affecting significantly larger percentage of population, then the PPV will go up, NPV will go down, sensitivity will not change, and specificity will also not change. And which parameter will likely lead to an increase in PPV of a test? Whenever the patient refuses to isolate, so then it will be increased prevalence. Whereas for all the other things, better treatment, better self-isolation, vaccine development, increased number of ICU beds will actually lead to decreased prevalence and decrease positive predictive value. Okay, question 104. A retrospective cohort trial is done to establish the relationship between long-term aspirin use and colorectal carcinoma. The relative risk is found to be 0.82 and the 95% confidence interval is 0.76 to 0.96. Again, it does not have the value of 1. Here we are doing the risk and not a difference, so we will give the value of 1. So that is already, we can see that it is statistically significant, right? And it feels that long-term aspirin use actually decreases the risk. Why? Because it is less than 1. So the p-value in this situation should be less than 0.05. So the correct answer is A, right? We know that for any result to be statistically significant, number 1, the 95% confidence interval should not contain the value of 1. If the relative risk is equal to 1, or if the 95% confidence interval has the value of 1, then the results are statistically insignificant, right? And if the value is lower than 1, then it means it is protective. Whereas if the value is greater than 1, then it means that it is basically a increase, like more risk to the population. And when the confidence interval does not contain the value 1, then the p-value should actually be less than 0.05. So that is the same thing over here. Relative risk is 0.82, 95% confidence interval is from 0.76 to 0.96, does not have the value of 1. So p-value should be any value that is less than 0.05, because confidence interval does not contain 1, so it is statistically significant. Question 105. The same trial was done simultaneously at a different center. Now they found the relative risk to be 0.87 and their confidence interval 95% was 0.7 to 1.15. Now this confidence interval has the value of 1. So it means that this is statistically insignificant. They also reported that they lost a significant percent of population to follow up, mostly those who were not taking aspirin. So this type of bias, because of losing a significant number of percentage of population, is known as a selection bias, also known as attrition bias, in which you lose a number of participants, right? So basically the group that you selected actually got lost in the process. This is known as a selection or attrition bias. Whereas overexposure of the over-reporting of exposure amongst the disease population is known as a recall bias. Observer having a strong belief in the existence or non-existence of association is known as observer bias. And then if there's improved survival due to early detection of disease without altering the course, this is known as lead time bias. Whereas a screening test that diagnoses diseases with longer latency periods is known as a length time bias. So so if we are having a particular statistically insignificant result, why? Because of the significant loss of participants, this is known as a selection bias, which is a type of attrition bias. Question 106. The investigators are looking into average fasting blood glucose levels among the patients in a primary clinic. The clinic takes care of 1,000 patients. The mean of the blood glucose levels for them is 90 milligrams per deciliter. Standard deviation is 10. Okay, let's plot it on our graph. Mean is 90 and the standard deviation is happening 1, 2, 3. Standard deviation is 10. We have to find out the number of patients who have blood glucose levels greater than 110, right? So if the mean is 90, in order to calculate greater than 110, that would be 10, 1 standard deviation, 10, 2 standard deviation, right? So 110, 100, and then 110, right? So that would be 2 standard deviation. You already know that 2 standard deviation is 68 and then 95, right? So 95%. And once a 2 standard deviation is 95%, we have to find greater than 110. It means that on each side it would be 2.5%, right? And how many people are they saying? They are saying they would take a total number of 1,000 people. So 1,000 multiplied by 0.25, if we do all the math, then we take the 25 divided by 100 and the answer comes out to be C, which is 25, right? Okay. And this is like simply by calculating that above 1 standard deviation would be 16%, above 2 standard deviation would be 2.5%, and above 3 standard deviation would be 0.15%. And if you have 1,000 number of patients, then you can simply multiply it 1,000 by 16, 1,000 by 2.5, 1,000 by 0.15 and calculate it. And remember, 1 standard deviation is 68%, 32% is left divided into 16% on each side. 2 standard deviation is 95% with 5% left, 2.5% on each side. Third standard deviation is 99.7, which has 0.3% total with 0.15% on each side. And so you can calculate the number of people who are above or below 1, 2, or 3 standard deviation, right? Question 107. A large clinical trial was done to assess the efficacy of a new diabetes drug. In the first phase of the trial, 7 volunteers were given the drug and no serious adverse effects were seen. The likely thing that is assessed during this phase. So first you should note that this is a phase in which volunteers are given who are healthy and they have no side effects. So this is phase 1. And what do we calculate for with phase 1? You know, we calculate STOP, right? Safety, toxicity, pharmacokinetics, and pharmacodynamics. So amongst these, choice D represents phase 1, whereas efficacy and dosing are compared basically in phase 2, in which there are moderate number of diseased peoples, and the comparison with standard of care is in phase 3, and in the black box warnings are in phase 4. Which of the following would most likely be assessed in the next phase? So this was the phase 1, right, in which pharmacokinetics, pharmacodynamics were discussed, right? We were found out. Now we are going to phase 2, in which dosing would be found out. So this is B. The correct answer is B, dosing, or it could also be dosing or the side effects or the efficacy of the drug. And if they ask after this phase, what would be tested? So that would be phase 3, in which we will do comparison with the standard of care. And after this would be the phase 4, in which we would do the black box warning. So we've already done that in the phase 1 of a particular trial, we assess for pharmacokinetics, pharmacodynamics, safety, toxicity. And the black box warnings are basically in phase 4. And if we talk about the next phase after phase 1, then we will evaluate for efficacy, adverse effects, and dosing. Okay. Question number 109. A group of public health officials is looking into developing a new screening program for an aggressive prostate cancer. The key here is a screening program. Which of the following feature would make it the most appropriate screening test? Remember, screening test with the N and sensitivity with the N. So the test with the highest sensitivity, that is D, 95%, would win as the best screening test, because we want to identify as many number of people as possible. We just want to keep the false negatives low, and we are not concerned about the false positives, because once we have the diagnostic test, right, the diagnostic test will have high specificity and low false positives, so it will eliminate all the false positives. So a screening test should have high sensitivity and a low false negative rate, right? So best screening test should have high sensitivity, low false negative rate. A best confirmatory test should have high specificity, low false positive rate, and the false negative for screening test should be low, and false positive for confirmatory test should be low, right? Because their sensitivity and specificity are higher. Okay, what test would be the appropriate confirmatory test? you can already like calculate it because of the thing that we already know, the formula that we already know, that the test with the highest specificity, that is A, would be the appropriate confirmatory test. A confirmatory test should have the highest specificity but the lowest false positive rate. It's highly specific means that the correctly people who identify it correctly identifies the people who do not have the condition. So the people who are like ruled out, they don't have the condition, they are correctly identified, right? And the false positives therefore we need to be low because you are actually going to like treat the patients, right, at this point. So there should not be any healthy patients who are actually coming out as positive, so we need to keep the false positives low, whereas false negatives need to remain low for the screening test, right? And with this concludes our discussion on the high yield rapid review biostatistics review. If you like this video, please like, share and subscribe and follow for more. Thank you for watching and happy studying.